In this video, we'll be studying the topic of stoma. Stoma is a surgically created opening on the surface of the body to allow the elimination of the waste or other bodily functions. Stoma are classified based on their purpose, duration, uh, location, and construction. Based on the purpose, this classification is determined by stoma's primary function. Firstly, being the feeding stoma. The purpose of the stoma is to provide nutrition directly into the gastrointestinal tract. For example, gastrostomy, which is an opening into the stomach for feeding, like shown in this diagram. Jejunostomy, where the feeding tube is directly inserted into the jejunum, as shown in this diagram. Excretory stoma. The purpose of the stoma is to eliminate waste, that is urine or feces, from the body. For example, colostomy that diverts stool from the colon to the abdominal surface. Ileostomy that diverts stool from the ileum to the abdominal surface, and urostomy which diverts urine through an opening into the abdominal wall. As shown in this diagram, we can see the ileostomy in the right iliac fossa region, the right colostomy, the transverse loop colostomy, and the left colostomy or sigmoid colostomy. Also, we can see the position of the feeding jejunostomy here. Venous stoma. The purpose of this stoma is to drain the body fluids or abscesses, like nephrostomy that is used to drain urine from the kidney, or even in cases of pyonephrosis, we can use this for drainage of the pus. Uh, Cholecystostomy, which drains the bile from the gallbladder. Another classification is based on the duration. That is, the classification depends on whether the stoma is temporary or permanent. Temporary stoma that is created for short-term use to allow healing of the affected organ. For example, temporary colostomy after bowel surgery, temporary ileostomy during treatment of Crohn's disease. Permanent stoma, created for long-term, lifelong use, often after removal of the diseased organ. For example, permanent colostomy after rectal surgery, permanent urostomy following bladder removal, etc. Based on location, this classification is based on anatomical site of the stoma. It may be a gastrointestinal stoma like colostomy, ileostomy, as we have already discussed. It may be a urinary stoma like urostomy or nephrostomy. Here we can see a picture of the nephrostomy where the nephrostomy is tube is directly inserted into the pelvis of the kidney, and it is exteriorized to the abdominal wall for collection of the pus or urine. And here we can see the tracheostomy where the tube is inserted uh, into the trachea directly through the neck, which is a kind of respiratory stoma. Based on the construction technique, this may be a end loop or double barrel stoma. Like in this first picture, we can see that single bowel loop is exteriorized. In the second, we can see a posterior wall in continuity, but anterior wall exteriorized as stoma. And in double barrel, we can see two different bowel loops exteriorized separately. So this is the same thing like end stoma. The end stoma of the organ, that is the bowel, is brought out to the surface and sutured to the skin. Typically permanent but may be temporary in some cases. Loop stoma, here a loop of bowel is brought to the surface with two openings. One of the stool, one is for stool or urine output, and another is for mucus fistula. Often used temporarily to divert the waste. Double barrel stoma. The bowel is divided and both ends are brought to the surface as separate stomas and with intervening skin, normal skin in between. One opening expels stools while other act as a mucus fistula, which is usually temporary. Coming to the ileostomy, an ileostomy is a surgical procedure which is a segment of in which the segment of ileum, that is a small intestine, is brought to the surface of the abdominal wall to create a stoma, allowing the passage of fecal waste. It is performed when the normal digestive pathway is disrupted due to disease, injury, or surgical resection of the colon. Unlike a colostomy, an ileostomy diverts liquid or semi-formed stool since it bypasses the colon, which normally absorbs water and electrolytes. Hence, the content is liquid or semi-formed stool. Coming to the indications of ileostomy, ileostomy is done mostly in cases of inflammatory bowel diseases like ulcerative colitis and Crohn's diseases, especially when the disease is severe and forming fistulas or with complications like strictures or stenosis or causing bowel obstruction. Secondly, colorectal malignancies, and after surgical resection also we do the ileostomy, like for colorectal cancer and for familial adenomatous polyposis surgery. Ileostomy can also be done for congenital malformations like Hirschsprung disease or intestinal pseudo obstruction as a functional bowel disorder. Also, after trauma and in emergency conditions, we may do ileostomy like bowel perforations, ischemic colitis, severe abdominal trauma, or also in cases of obstructed or ruptured diverticulitis leading to peritonitis. Sometimes temporary fecal diversion is done in the form of an ileostomy, which is protective in cases of anastomosis done in lower anterior resections. Types of ileostomy, based on the duration, it may be classified as temporary or permanent, as we have already discussed, and depending on the surgical technique, it may be a end, loop, or double barrel stoma. Surgical procedure for ileostomy creation is firstly the pre-operative preparation. That is, the bowel preparation is required in selective cases. Nutritional optimization with high protein diet, hydration, and correction of anemia. Preoperative stoma marking, like stoma care nurse should identify the best site for patient's comfort and appliance uh, appliance adherence. Informed consent should be taken with proper explanation of the risk, benefit, as well as the procedure and lifestyle adaptations following the procedure. Surgical steps include essentially the anesthesia of general anesthesia and incision and ileal mobilization includes a small incision is made in the desired site and the ileum is brought out for the abdominal wall. This is done mostly in the right iliac fossa, and the incision is a linear one in cases of temporary stoma, and it may be a disc-shaped incision in the permanent stoma. Creation of the stomata, ileum is everted, that is turned outward and sutured into the skin as well as into the fascia to create a well protruding stoma. Placement of the ileostomy bag, a pouching system is attached to collect the stool that is coming out from the ileostomy. Postoperative care and stoma management. Firstly comes the immediate postoperative care. We have to monitor for complications like bleeding, leakage, or significant sign of infections. Also, with proper analgesic, we need to manage the post-surgical pain. Regarding diet and hydration, we can start the clear fluid as early as possible, preferably as soon as the bowel sounds reappear, or the next day also only we can start the fluids depending on the etiology for which the stoma was done. Followed by a low fiber diet to prevent excessive stool output. Electrolyte monitoring should be done to prevent dyselectrolytemia, particularly loss of sodium, potassium, and fluids. Early mobilization reduces the risk of deep brain thrombosis and also promotes the gut motility. Coming to stomach care and management, regular emptying of the ileostomy bag every 4 to 6 hours to prevent the overflow of the bag. Skin protection, there is use of skin barriers and protective rings to prevent peristomal skin irritations. Observation of the stoma health is done routinely and it should be pink to red, moist and protruding stoma. Avoiding stoma blockage. Patients should chew food thoroughly to avoid high fiber foods like nuts, seeds, and raw vegetables that may cause blockage of the stomach. Dietary guideline: high fluid intake to prevent dehydration due to continuous stool output. Electrolyte-rich foods like bananas, potatoes, and sport drinks to replenish potassium and sodium. Low fiber diet initially and gradual reintroduction of fiber to prevent obstruction. What are the complications of ileostomy? Early complications big stomal necrosis, as we can see in the first picture, due to inadequate blood supply and requiring urgent revision of the stoma. Peristomal skin excoriation, which is the most common complication following a stoma. Ileus and bowel obstruction, which is usually temporary paralysis of the bowel post-surgical, and that resolved with correction of the dyselectrolytemia and dehydration, and sometimes on its own. High output syndrome, like excessive fluid and electrolyte loss requiring IV rehydration. Late complications being stoma retraction, as we can see in this image, like stoma is retracted back into the abdominal cavity and with detachment from the surrounding skin and the fascia. Also, we can see the wound diseases in this picture due to poor nutrition of the patient, particularly. Peristomal hernia and stromal prolapse. Here in this picture, we can see the bowel loop directly coming out through the stroma, which is known as the stromal prolapse. And if it comes out in the adjacent weak bowel wall, it is known as the peristomal hernia. And vitamin B12 deficiency due to loss of terminal ileum absorption, which is responsible for absorption of vitamin B12. And this requires supplementation of the vitamin B12. Ileostomy reversal, there is closure of the temporary ileostomy, which is performed usually 6 to 12 weeks after the initial surgery once the underlying disease for which the bowel for which this ileostomy was done. The stoma is surgically closed and intestinal continuity is restored again. And the prerequisite before doing the closure of the stoma is the contrast study, that is the distal loop cologram or distal lupogram to visualize the distal colon so that there is no obstruction or the pathology has been resolved. Here is a picture of distal loop cologram, and we can see that the whole contrast is going up to the rectum. as the distal loop is patent. Now, regarding the patient education and adaptation, stomach care training, patient learn how to empty and change their ileostomy bag. Psychological support like counseling to help the body image and social adaptations. Lifestyle adjustments, that is guidance on exercise, diet, and resuming daily activities. Prognosis and quality of life. Most patients adapt well with proper stomach care and lifestyle modifications. Temporary ileostomy can be successfully reversed, restoring normal bowel function. Permanent ileostomy require long-term adaptation, but patients can live active, independent lives. Coming to colostomy, which is a surgical procedure that creates an opening of that is the stoma in the abdominal wall through which the part of colon is brought out to the surface to allow the passage of stool. The stoma serves as an alternative route for fecal elimination when the normal pathway is obstructed or removed due to disease, trauma, or congenital conditions. Depending on the underlying conditions, a colostomy may be temporary or permanent. Indication for colostomy: congenital conditions like anorectal malformations, that is imperforate anus, cloacal abnormalities, etc. Hispunk disease, that is aganglionic megacolon. Secondly, malignant conditions like colorectal cancer or pelvic tumors, which obstructing and inoperable colorectal carcinomas, where the colostomy is done as a palliative procedure. Following abdominal pulmonary resection for rectal cancer, there may be a permanent end colostomy. Traumatic or surgical cases like colonic perforation due to trauma or injury to the rectum or colon, complications from pelvic surgeries like iatrogenic bowel injuries, and inflammatory and infectious conditions like diverticulitis with perforation, complicated Crohn's disease or ulcerative colitis, tubercular or ischemic colitis, etc. For intestinal obstruction or fistula formation, also we can do the colostomy, particularly in cases of obstructive colonic strictures like benign or malignant strictures, entrovesical or enterocutaneous fistulas, as fecal diversion allows the fistula to heal rapidly. Fecal diversion in complex perineal wounds like fournier gangrene, perineal fistulas, and severe hemorrhoidal conditions. Coming to the types of colostomy, which is similar to ileostomy, like temporary and permanent based on the duration and based on the anatomical location, it may be ascending, transverse, descending, or sigmoid colostomy. And on depending on the surgical technique, it may be end, loop, or double barrel colostomy. The procedure is almost similar to that of ileostomy. The thing different is that we need not pout the colostomy, but it will be flat the surface of the at the level of the abdominal wall. Preoperative preparation also similar like bowel preparation, nutritional optimization, preoperative stoma site marking, and informed consent. Surgical steps, anesthesia is also same like ileostomy, that is general anesthesia, incision and bowel mobilization, creation of the stoma, and fixation and skin maturation and placement of colostomy bag. These are all similar to the ileostomy as we have previously discussed. Postoperative care and stoma management includes immediate postoperative care like monitor for complications like infection, peristomal skin irritation and bleeding, pain management with proper anesthesia, IV fluids and gradual diet advancement and early mobilization to prevent DVT and enhancement of the bowel function recovery. Colostomy care is also similar to ileostomy, that is emptying the colostomy bag every 4 to 6 hours or when it is one third full. Skin care for preventing skin excoriations, avoiding skin irritations, and monitoring stomach color for any ischemia or necrosis. Dietary guidelines could include avoid gas-producing foods like cabbage, beans, carbonated drinks, etc. Eat fiber-rich food like for particularly sigmoid colostomies. Maintain hydration. What are the complications of colostomy? These are similar to like ileostomy, like stromal necrosis, peristomal skin irritation or infection, bowel obstruction, paralytic ileus, etc. Lead complication being the stromal prolapse, stromal retraction, peristomal hernia, colostomy stricture, etc. Psychology and social issue like depression, body image disturbance, and anxiety related to colostomy use is also observed in some cases. Regarding colostomy closure, that is the closure of the temporary colostomy, which is performed when the primary condition has been resolved, usually done after 6 to 12 weeks, and requires contrast enema study, that is distal loop program or distal loopogram. Patient education and rehabilitation includes colostomy and self-care training, supporting group and counseling, and psychosocial rehabilitation. Prognosis and quality of life. Most of the patients adapt well with proper training and support. Permanent colostomies require long-term adjustments, but patient can lead active lives. Advances in stoma care and colostomy appliances have improved comfort and hygiene in colostomy and ileostomy cases. Coming to the differences between ileostomy and colostomy. First, the definition being the surgical ileostomy being a surgical opening in the ileum, where colostomy is a surgical opening into the colon, and both are extravased into the abdominal wall to divert the stool. Location of the stoma, usually ileostomy is in the right lower quadrant of the abdomen, and colostomy is the left lower quadrant, depending on the, and it may be also done in the right upper quadrant in cases of transversal colostomies. Types of stool: the ileostomy output is liquid to semi-liquid, and colostomy output is soft to firm stool, depending on the location of the colostomy. The frequency of output is usually 4 to 6 times per day in case of ileostomy, and less frequent, that is 1 to 2 times per day in colostomies. Indications we have already mentioned separately for ileostomy and colostomy. Digestive functions, as the colon is bypassed in ileostomy, this leads to increased fluid and electrolyte loss, which is less seen in case of colostomies. The risk of dehydration is more in case of ileostomy, as the uh, output is liquid to semi-solid, and it is less in cases of colostomies, as there is some absorption in the remaining portion of the colon. Nutritional considerations require high fluid intake and electrolyte-rich fluid in cases of ileostomy, and patient can tolerate normal diet well in cases of colostomies. Stoma appliances, stoma appearance. That is, a stoma is protruded, moist, and red and pink in cases of ileostomy, and flash stoma is skin, that is at the level of the skin in cases of colostomies. Skincare needs are intensive in cases of ileostomies, and these are less irritation since stool is more solid in cases of colostomies. Gas and odor. Less gas and odor is seen in cases of ileostomy, and more odor and gas seen due to bacterial breakdown in the colon. Stoma bag, particularly drainable open-ended pouch to allow frequent emptying in cases of ileostomy, and closed-ended pouch or desired drainable bags depending on the stool consistency in cases of colostomies. Reversal surgery often temporary, ileostomy are often temporary and can be reversed after underlying condition heals. Same for colostomy also, depending on the indication for which the colostomy was done. In this picture, we can see the pouting, that is the extension of the bowel loop in case of ileostomy up to 2 to 3 centimeters above the skin level. But in cases of colostomy, it is at the level of the skin. Finally, an ileostomy is performed when the entire colon needs to be bypassed as a result of liquid stool with high fluid loss requiring careful hydration and skin protection. A colostomy otherwise retains the part of the colon and producing form stool with more predictable output, requiring less intensive management. The choice between these two depends on the underlying disease, bowel function, and surgical necessity. Coming to some of the common questions, that is the direction of the proximal lobes. The proximal lobes should be downward and laterally directing, so that the output is directly falling into the bag, and it is in the dependent side. Breach in the stomach, as we can see in this image, there is a breach used for prevention of the retraction of the stomach, and previously we used to use grass swords, but nowadays we use rice tube catheters or feeding tubes, etc. Stoma triangle, this is the triangle bounded by the umbilicus, anterior superior iliac spine, and pubic symphysis, and uh, we joined the apex to the opposite midpoint, and intersection of all these three forms the site of the stoma. And perioperative marking of the stoma depends on multiple positions like sitting, standing, and bending. In all these cases and all these positions, we should check for the position of the stoma, and then only we should mark. And we should avoid the scars, folds, drain sides, and costal margins, and iliac crest, that is the bony prominences. The stoma should be away from all this. It should be away from the belt line, and it should be within the rectus muscle, and the visualization of the stoma by the patient should be well, and it should be in the intraumbilical fat bed. The skin incision, it is usually circular or disc-like in cases of M stoma, and linear in cases of temporary stoma. Functions of the loops, there is a proximal loop, act as a drainage stoma for stool, and distal loop act as a mucus fistula. Types of stoma bags, and here we can see the one-piece stoma bag here, where we can see there is a clamp or closure here, and from which the content can be exteriorized. And here in this hole, we can make it of desirable size, and then we can, as per the stoma size, we can apply it directly into the skin. But in this two pieces system, here there is an adhesive, Okay, and this is a separate piece, and the flange is a separate piece. And so first this will be stick surrounding the stoma. Depending on the size of the stoma, we need to cut the center part, and then above it we can apply this flange and tighten it. In this last picture, we can see the single-use stoma bags which are used for single time, and there is no drainage output like in the first image, and this can be used for once, and then we have to remove it and throw it and apply in another bag. This is a bit cumbersome, and also the excavation of the skin is higher in these cases. So this was about the stoma. Thank you.